Good afternoon, everyone. This is Dr. Qassid. I'm one of the consultant breast pathologists in Northamptonshire in England. Today, I would like to speak about the prognostic and the predictive factors in breast cancer. Before I start, I would like to make a disclaimer. I'm not paid for promoting products, and I have no personal interest or conflicts with any party or any content of this presentation. Here's the outlines. So before we start, why do we need to know about the prognostic and predictive factors in breast cancer? Well, from the name, it's prognostic and predictive. This will help us to stratify patients into the ones which are going to do good or poor, and the ones which are going to respond better to the treatments. By treatment, I mean hormonal therapy, chemotherapy, and the biologic therapies. So the way we do this is by light microscopy. With that, we can tell the nodal stage, tumor size, grade, type of the tumor. As you know, some types of the tumors have a better prognosis than the others. The second tool is the ancillary tests or molecular tests. And we can do this by immunochemical stains or more sophisticated multigene assays. In this graph, we can see that the better the grade of the tumor is a better survival. The same applies for tumor size. The smaller the tumor is a better survival. So it's very important to accurately measure the tumor size histologically and not to rely completely on macroscopy or radiological size. The presence and absence of vascular invasion has also shown a great effect on survival, which of course can affect the nodal stage. And you can see that the node negative disease have a better survival than the one which got the higher nodal stage. This is another graph showing almost the same results. Moving to the molecular factors. So of these, we have the estrogen receptor, the very famous one, and the progesterone, HER2, and in few centers, they do some proliferation markers like Ki67, P53, etc. And in the second part of this presentation, we will talk about the multigene assay. So let's move to the first part. Estrogen. The estrogen receptor is expressed in majority of the tumors. And there are quite few scoring methods. The most famous one is the Hedge score, which is a score of 100%, and the quick all-red score. Let's take the quick all-red score as an example. So with this one, we will be scoring the percentage of tumor cells showing the staining and also the intensity of the tumor staining. This will come up with a score of 8. The reason why we care about this is because of the response to endocrine therapy, because hormone positive treatment, the reason why we care about this is because hormone positive tumors will receive hormone treatment or endocrine treatment. Like, for example, tamoxifen, aromatase inhibitor. So the tumors with no staining to estrogen will receive no therapy. And the higher the score of the quick or the high or the edge score, the better response to the therapy, endocrine therapy, I mean. The progesterone will follow the same principles of estrogen. So moving to the HER2, and this is expressed in 10 to 30% of the breast cancers, and majority of these tumors tend to be a higher grade, like 2 or 3. And again, the importance of checking for HER2 or establishing if the tumor is a HER2 expressed is because of the anti-HER2 treatment, Herceptin. The way we do it again is by immunohistochemical stains in a score of 0 to 3, where 0 is no staining, 1 is weak but incomplete, membranous staining, and a borderline stain of 2+, which is a complete but weak, and 3, as you can see, it's a crisp, linear, membranous, complete. The equivocal score of the 2+ will undergo a further, more sensitive, more specific testing, which is in situ hybridization to check for amplification of the HER2 gene. And this will come up into either amplified or not amplified. So that not amplified historically will receive no anti-HER2 treatment. And of course, the amplified will be compatible for the anti-HER2 treatment. However, recently things have changed. So the HER2 have been rescored into a HER2 low and ultra low, and a HER2 negative, and of course a HER2 positive. So the HER2 positive is straight for anti-HER2 treatment, but the low and the ultra low will also be receiving other approved FDA drugs of anti-HER2. I encourage everyone to search more in that and have a more careful discussion with their oncologist, because I think it's quite a new thing. So on the basis of the two, the morphologic and the molecular, we can classify the breast cancer into 4 types. A luminal A tumor, and this is the good guy one, basically. So this is a hormone positive, HER2 negative tumors. This have a very low proliferation rate. So these tumors respond very well to hormone therapy, but have a very minimal response to chemotherapy. The second type is the luminal B. This is almost identical to luminal A, but having a higher proliferation index. So they are either a hormone positive HER2 negative, but there is another subtype of it, which is hormone positive HER2 positive. The latter you can see in BRCA2 and TP53 mutation patients. These have a poorer prognosis than luminal A, and they respond better to chemotherapy than luminal A. The third type, which is HER2 enriched, this is a hormone negative HER2 positive. This have the worst prognosis compared to the previous two. This is also seen in BRCA2 and TP53 mutation. These patients respond better to anti-HER2 and to chemotherapy. The fourth type and the final type is a triple negative, when everything is negative. So it's ER negative, PR negative, and HER2 negative. This is a big group of diseases. Some of them have a good prognosis. Others have the worst. Of the good prognosis one, like salivary type, adenoid cystic, for example. So these type of tumors, although they triple negative, but they have a better prognosis than metaplastic carcinoma, for example, which is which is a triple negative. These type of tumors also have a higher response or a better response to chemotherapy. Other prognostic factors which we can test is, of course, have to focus more on what makes cells proliferate and what we can do to suppress the growth of this, or at least have an idea on how this tumor is going to behave. The way to check this is by a little bit more complex tools than a simple immunohistochemical stain. And this is where we're going, the multigene assay. There are quite few techniques or providers for this, but I think the most famous one worldwide is the Oncotype DX and the Prosigna, the PAM50. So now, how to choose these patients that can go to these type of testing? Now, the reason why we do this testing is basically to determine whether these patients will require chemotherapy or not. So the patients which have low response to chemotherapy are the luminal A and luminal B HER2 negative. Yeah, because these are the ones which are not going to respond well to chemotherapy. So these are the patients who can have the extra testing just to see how this tumor could behave, and if the tumor is behaving in a more kind of a sinister way, then we can give the adjuvant chemotherapy. So the condition number one, you should have an ER positive, HER2 negative tumor. And in NICE guidelines, you also need to have a nodal status of 0, so node negative disease. If these patients have a score, an MPI score, a Nottingham Prognostic Index score of more than 3.4, or a predict score 2 to 4%, then the sample can be sent for multigene assay. I will elaborate more on this, but let's take each bit by bit. Okay, so the NPI, which is Nottingham Prognostic Index, this is a simple equation which you multiply the cancer size in centimeters by 0.2 plus the grade, which is, as you know, we have grade 1 or grade 2 or grade 3, so you can, for example, +2 here, and then the nodal stage, which is 1 to 3, when N0 is scoring 1 here. So then you will have a score, and if the score is more than 3.4, then these patients will go straight to multigene assay. Yeah. The second tool is Predict NHS. Now, this is a useful online tool that anyone can use. Okay, and I encourage you to encourage the oncologists to use this. So this is the website, which is predict.nhs.uk, and then you can come up with this front page and then start Predict. Then you can type the patient parameters like size, age, etc., and then you will have a score. Then you will have a table at the end, which will have a percentage of benefit to chemotherapy. If the percentage is 2 to 4, then this is where you have to send for multigene assay. If the score is below 2, then that's when chemotherapy is not indicated. Having said that, if the score is more than 4 or 5 or 6, that's when we should have a discussion with the patient about adjuvant chemotherapy. Yeah. So this is the Oncotype DX. So Oncotype DX test for 21 genes of those, like I said to you, it's a proliferation, suppression, some some intrinsic genes, and it will come up with a recurrence score. You will see at the bottom of the report a score. If the score is below 25, that's where low risk group happens, and there will be the oncologist will not offer chemotherapy. Okay, if the score is higher, then that's when the oncologist will consider giving chemotherapy to the patient. I'll show you an example of this. This is the kind of a sample report you get from Oncotype DX. See here, the score is 32, which means it's a higher risk group. In this, patients will have a discussion. In this, the oncologist will have a discussion with the patient in regards to adjuvant chemotherapy. Now, the only issue with Oncotype DX, which everyone know, that the sample has to travel to America to have it tested, yeah, and it's quite costly. It's almost £3,000 for the test, but it's quite useful. The second test is PAM50. So the PAM50 stands for Prediction Analysis of Microarray 50, and the 50 is the number of genes tested by this tool. And the company which is basically running this is called Prosigna. So the number one advantage is that you can have this machine in-house. So you can have you can have an in-house genomics, or you can have a regional, for example, a regional machine that can take samples from all over the country. Currently in Britain, we have one in Guildford, which runs, which receives samples from quite a few cities in the south and in the Midlands. Okay. Other machines are present in universities for purposes of research, but I'm only mentioning the one in service for patient care. So this is a small machine. It's almost like a tabletop, yeah. And this machine is called the Encounter DX Analyzer, yeah. And it's 5 pieces, and this will take all the work and give you a result which would look like this. I'll show you in a minute. So the way this is done is by looking at 800 genes in the same time, and come up with an equation that will identify the intrinsic subtype of the tumor. So it will tell you if this tumor actually is a true luminal A, true luminal B, or basal-like, or a HER2 enriched disease. It will also tell you another useful thing, which is risk of recurrence, the ROR. So this is, if you, at the bottom, you can see here, like this is the sample report. You can see the scoring is different from the oncotype. Here you have 3 tier categories. So you have a low, intermediate, and high risk. So that on the left side of the screen, you see the full report, and you see here that the subtype of the tumor is a luminal A, and it's scoring 25. So it's in the low risk. Of course, this has to reciprocate in the other graph, and you will see that the low risk tumors, the luminal A, will have, of course, a low risk of recurrence. A similar thing, if we have a high risk tumor, like for example luminal B here, will of course have a higher risk of recurrence. This is a simple table just to give you an idea, on what each provider can provide to you. So the Prosigna and the Oncotype are both FDA and NICE cleared. The Prosigna is superior, that you can have it in-house. When Oncotype, you should send it to the other side of the globe. Prosigna tests for 50 genes in compared to 21 genes in Oncotype. So again, sometimes it's very difficult to choose between legends. These have been in the market for almost a decade, so it depends on what oncologists favor and what kind of, patient samples you have. But always come to the cost. So Prosigna cost around £1,400 when Oncotype DX is more than 3 grants. And thank you very much. I would like to thank Professor Imad Raka for providing some of these data